Visual acuity is the most important ocular vital sign. Consultants expect this information when you seek their help. By the end of this activity, you will demonstrate the ability to obtain and document an accurate visual acuity on a patient with an acute ocular eye complaint. And you'll be able to describe the clinical scenario where treatment is performed prior to visual acuity acquisition. Why is visual acuity testing important, you ask? Because it is the single best snapshot of visual function. It drives management decisions. It drives the decision for consultation. It can be performed quickly. It is reproducible. It is easy to standardize and communicate. Visual acuity can localize the problem. Visual acuity provides an objective baseline to measure a change in an ocular condition. The presence of decreased visual acuity suggests a vision-threatening condition. The first step in the visual acuity examination is to have the patient put on their corrective lenses if they have them. Then place the patient precisely 20 feet from the Snellen chart. Cover the left eye. In this patient, we are using a commercial occluder. Start at the lowest line the patient can read. Encourage patient to read the next lines. They may need to be strongly encouraged. Credit for a line is given if the patient accurately identifies 50% of the letters. In this case, the patient read E, D, F, C, but missed Z and P. They have correctly identified greater than 50% of the letters and therefore get credit for line 6, which is documented as 20/30 in the right eye. Repeat the process for the other eye. In this case, the patient read DEFPOTEC or DEFPOTEC and gets credit for line 8, which is 20/20 vision. Let's go over the correct way to document visual acuity. The V and the A stand for visual acuity. OD means ocular dexter or right eye, so 20/30 is the right eye visual acuity. OS means ocular sinister or left eye, so 20/20 OS is the left eye visual acuity. The numerator is the distance of the patient from the chart, typically 20 feet. The denominator is the distance from which a person with normal vision would read the line with greater than 50% accuracy. The C indicates visual acuity measured with correction. The S indicates visual acuity measured without correction. But what if a patient cannot get to or stand in front of a Snellen chart? Trauma or elderly patients may not be able to stand or read a Snellen chart, so a Rosenbaum card held 14 inches away from the eyes may be used. What if a patient does not know their letters?
What do we do?
They're all mixed up.
Oh no!
Use a kindergarten eye chart at 20 feet. What if the patient cannot read? Use an illiterate eye chart and ask the patient to point to the direction the E is oriented. What if the patient's visual acuity is diminished from baseline? If the patient's visual acuity is diminished from baseline, use a pinhole to reduce refractory error. A pinhole reduces the number of beams, thus reducing the size of the blur circle on the retina. This is built into an occluder, or you can make your own using a pencil and paper. The letters PH after visual acuity mean a pinhole was used to achieve this visual acuity. What if you are performing visual acuity testing and your patient cannot read the big E? Then move the patient 10 feet from the chart and simply change the numerator. What if they still can't read the big E? Then move the patient 5 feet from the chart and simply change the numerator. What if the patient still can't read the big E? Then have the patient count fingers at 1 to 3 feet. But what if they can't count fingers? If the patient cannot count fingers, assess if they can detect hand motion. What if the patient cannot detect hand motion? If they cannot detect hand motion, then determine if they can detect light perception by moving a light in their field of view. If they cannot perceive light, this is bad and is designated as NLP or no light perception. This chart depicts the range of visual acuity from excellent vision to no light perception. You should know this chart. I want to list the 5 most important visual acuity examination tips. In patients with an ocular complaint, when possible, obtain a visual acuity examination first. The exception is a chemical injury where you should irrigate prior to visual acuity. This will be a test question. Establish the best corrected visual acuity, which means if the patient wears corrective lenses, they should wear them for the visual acuity examination. Visual acuity is best performed before the installation of dilation drops. Topical anesthetic will facilitate visual acuity examination if your patient is in pain. Remember that visual acuity only checks the central vision. Test each eye individually, affected eye first or the right eye first, then the other. Know the steps from normal vision of 20/20 to no light perception. Know that DEFPOTEC or DEFPOTEC is 20/20 vision or line 8 on the Snellen chart.